In my practice as a headache neurologist, I'm usually manipulating triptans at the moment because patients, of course, have had simple analgesics and non-steroidals. And what I'm doing is looking for the best triptan in an individual. And that can depend on speed of response, it could depend on side effects, it could depend on recurrence. I'm pairing the triptan with typically with naproxen to try and increase efficacy and reduce headache recurrence. On the preventive side, what I'm looking at on the preventive side is really trying to match the patient to the side effect in many ways, because most of all the preventives we have some sort of side effect. And what I find myself doing is setting out the side effects and having a discussion with the patient around which one bothers them the least, which is usually the medicine path that we go down.
There are a large number of evidence-based acute treatments for migraine. There are 7 triptans that are FDA approved in the United States, and there is only 1 nonsteroidal anti-inflammatory that's FDA approved. And then there are a number of combination analgesic products that are FDA approved, as well as some simple analgesics, like a number of preparations of ibuprofen that are FDA approved for migraine. When it comes to choosing an acute treatment for migraine, the first issue is simply how severe are the attacks and how frequently do they occur. So if the attacks are infrequent and relatively mild, some of the over-the-counter medications may be sufficient to help the patient manage pain, particularly if they take the acute treatment early in the attack while pain is still mild. For other patients with more severe attacks, a number of triptans are good options. All of the triptans are available orally, but some of them are available through non-oral routes of administration. And those non-oral routes of administration are particularly important in several groups of patients. So if a patient regularly vomits early in the attack, obviously taking an oral medication isn't a good strategy. But even in patients with severe nausea, they may not be able to take an oral pill, or they may have difficulty absorbing the oral medication. So people think of treatment effects beginning when the patient puts the pill in their mouth and swallows it, but the reality is the treatment effects begin when the drug reaches its critical levels at the active site where it works. So if the drug's not absorbed, obviously the drug can't work. So there's several injectable formulations of sumatriptan. There's several nasal spray formulations of sumatriptan too, and the better nasal spray formulations are the ones that are rapidly absorbed. There's also a nasal spray formulation of zolmitriptan, and then many other efforts underway to find ways of getting drugs into people's bodies during a migraine attack, circumventing the gut. And again, that's important in the subgroup of patients who have gastric paresis, whose digestive system is paralyzed, who might not be able to well absorb the drug during the attack.
How do I pick a medicine for a patient? It depends on how old they are, whether or not they're childbearing potential, what they've tried in the past, and are there any medical problems. So the average younger patient, the choice would be many times asking them, what have you tried? And if it doesn't work, you don't repeat it. But if it does work partially, you figure out what you can do to make it better. So the 2 major choices we have, nonsteroidals alone or in combination with a triptan, and then something like compazine for a rescue medicine in case the headache doesn't come under control.
For preventive treatments, the first pass thing to do, having established someone needs a preventive, is to work out if there are any therapies they can't tolerate, because there's no point offering people things they can't take. So I'm not going to offer a beta blocker, propranolol, to someone who has asthma, for example. I'm not going to offer topiramate to someone who's got a history of kidney stones. I'm not going to offer Candesartan, a blood pressure lowering drug, to someone whose blood pressure's to their boots already. So it's first, what's contraindicated? What do I need to take off the table? And after I've done that, I think it's really useful to set out some choices and let the patient decide which one they want to take. Because if someone says they want to take that, rather than you tell them you must take it, the chance that they'll take it is greatly increased if they took the decision. So I think a crucial thing in prevention, well, it's true of all migraine therapy, is to make sure the patient is an active participant in the decision that you're taking, so they understand why they're taking it and that they actually want to take what you're going to give them.